Good morning. I am Dr. Chandrasekhar, Professor and HOD of Ophthalmology Department. And now I am going to discuss you with regarding conjunctivitis. What is conjunctivitis? What are the causes for conjunctivitis? How to prevent conjunctivitis? And if at all we get conjunctivitis, what are the treatments available? And how to diagnose? And what are the complications of conjunctivitis? I hope definitely this video presentation will be helpful for the younger generations to know in detail about conjunctivitis. Conjunctivitis. Here we are going to see what is the history behind conjunctivitis, what is the method, what are the methods of examination, what is the etiology, what is the pathophysiology, what are the ocular features of conjunctivitis, and what are the differential diagnoses we can make on conjunctivitis, and what are the complications, of course, the management. What is conjunctivitis? Conjunctivitis is an inflammation or infection of the conjunctiva associated with discharge, which may be watery, that we call it as serous, then mucoid, then mucopurulent, and purulent. Here, the purulent is supposed to be the severest form. Coming into the various types of conjunctivitis, we have got infectious conjunctivitis and non-infectious conjunctivitis. What are all the infectious conjunctivitis we have? We have bacterial conjunctivitis, viral conjunctivitis, then we have got severe form of conjunctivitis called as ophthalmia neonatorum. Normally we never see that nowadays. And we have got granulomatous conjunctivitis. It is mainly concerned with granulomatous disorders like tuberculosis, syphilis, and sarcoidosis. And these are all infectious conjunctivitis. Coming into the non-infectious conjunctivitis, we have got allergic conjunctivitis. In that, we have got perennial conjunctivitis, we have got seasonal conjunctivitis, atopic conjunctivitis, and we have got vernal conjunctivitis. Apart from that, cicatricial immune-mediated conjunctivitis, then irritative and mechanical or toxic conjunctivitis, and last but not the least, the neoplastic conjunctivitis. The neoplastic conjunctivitis means we get in squamous cell carcinoma, sebaceous carcinoma, as well as in melanomas. And coming into the organisms which are producing these conjunctivitis, we have got the conjunctivitis basically divided into acute, subacute, chronic varieties. Acute means in 1 or 2 days, the conjunctivitis after prodromal stage, it will flare up. It will become more after 3 to 5 days, and then it will subside by itself. Then we have got chronic variety. The causes are plenty for that. And coming into the subacute variety, if there is history of remission and reattacks, we call it a subacute attack. And coming into the organisms producing conjunctivitis, we have got Staphylococcus aureus, which is the commonest organism producing. And then we have got Staphylococcus itself, we have got epidermidis, we have got pyogens, then we have got Streptococcal pneumoniae, which can produce petechial hemorrhages. And of course, we have got the gram-negative organism producing conjunctivitis like Haemophilus influenza. We call it familiarly as Koch-Weeks bacillus. And this Koch-Weeks bacillus can produce pseudomembrane formation. And of course, we have got other organisms like Moraxella lacunata. This Moraxella lacunata can produce angular conjunctivitis. And apart from that, we have got Neisseria gonorrhea and Neisseria meningitis and Clostridium diphtheriae bacilli. And of course, nowadays we see very rarely this Neisseria, gonorrhea, and diphtheria organisms. And this is regarding the acute bacterial conjunctivitis. Coming into another type of conjunctivitis, we have got chlamydial conjunctivitis. People may not know what is chlamydia. It is in between bacteria and virus. It is more gram negative. It produces inclusion bodies, and the popular chlamydia what we have is chlamydial trachomatosis. It can produce infection in the infants as well as in the adult. In the adult, it can produce inclusion conjunctivitis. It is mainly genital infections. And we have got type 1 and type 2. And coming into the neonatal inclusion conjunctivitis. And this is one of the commonest cause of conjunctivitis which occur in the newborn. And previously, gonococcus was the culprit. Now we see more of inclusion conjunctivitis, especially chlamydia. This chlamydia has got so many species: A, B, BA, C, D to K. Then up to A, B, BA, C, it can produce blindness due to these serotypes, and from D to K, it is mainly genital involvement. So a genital cause is responsible for from D to K type of chlamydia. Coming into the viral conjunctivitis, we have got adenovirus, we have got herpes, which is very common. Among the herpes, we have got simplex and zoster. And of course, we have got molluscum contagiosum, and then myxoviruses, paramyxoviruses, picornoviruses, that is mainly responsible for hemorrhagic conjunctivitis. And of course, we have got enteroviruses also. In this, we have got adenovirus, the strain 8 and 19, which is mainly responsible for epidemic keratoconjunctivitis. And strain 347 is mainly responsible for pharyngoconjunctival fever, and mainly the conjunctiva is involved in pharyngoconjunctival fever. Patient will be having fever, sore throat, and conjunctivitis. In epidemic conjunctivitis, the strain is 8 and 19. Coming to the clinical features of conjunctivitis, the patient may have severe discomfort. He will have a sandy sensation, gritty sensation, lacrimation, burning sensation. Of course, a foreign body sensation may be there always. And the patient may have redness. The redness of the conjunctiva will be diffuse. Not only that, if corneal involvement is there, there will be a photophobia. Photophobia means increased sensitivity to light. They cannot see the bright light. They will try to have blepharospasm. And coming into the discharge, it may be a mucoid, or it can be a purulent, or it can be a mucopurulent. Depending upon the severity of the infection, we get the varieties of discharge. And sometimes, what is the clinical feature? So coming into the clinical features, there may be conjunctival ingestion. You all know that conjunctiva is supplied by marginal and palpebral arcade. And not only that, we have got a circumcorneal congestion also. And this conjunctival ingestion will have some edema of the conjunctiva also. This we call it as familiarly as chemosis. Apart from that, we have got lid edema, lid erythema. Erythema means redness. Apart from that, we have got papillary hypertrophy. First of all, you should know what is papilla and follicle. Papilla is nothing but whatever the existing conjunctival vessels will get hypertrophied. So, in all types of conjunctivitis, we see that papillary hypertrophy, especially in case of allergic type of conjunctivitis. And coming into the follicles, so whatever the lymph follicles which are present, that will get proliferated, and this will be seen in drug induced as well as in viral infections. Coming into the corneal involvement, we will have superficial punctate opacification. Sometimes we get epithelial erosions, sometimes ulcer formation, as in the case of vernal catarrh, allergic conjunctivitis, we get shield ulcers. And coming into the hemorrhages, sometimes we see hemorrhages also occurring in the bulbar conjunctiva. You all know that hemorrhages is mainly produced, it will look like a subconjunctival hemorrhage. And this hemorrhage is mainly formed by a picornovirus. Sometimes pneumococcus also produces petechial hemorrhages. So a corneal involvement also may be there in case of conjunctivitis. And especially we can see in gonococcal and meningococcal infections. What are the predisposing factors for conjunctivitis to occur? It is nothing but poor hygienic condition, hot, dry climate, poor sanitation, chronic exposure to the fumes, dust, irritants, and the local causes of are foreign body present in the sulcus subtarsalis, that is in the marginal conjunctiva, and coming into trichiasis. Sometimes this misdirection of the lashes also can produce maybe the predisposing factor. And eye strain. So patients may be having a refractive error. They may not aware that they should wear glasses. And sometimes patients will have convergence insufficiency. That also can lead to this type of problem. And sometimes abuse of alcohol, insomnia. People, they are with the computers or with the mobile for a long time, and there may be insomnia may be there, and metabolic disorders also may be one of the predisposing factors. So what are all the predisposing factors? Any one or two may be together. And coming into the investigations, what we are going to do for these patients. Normally, the route for the acute cases, it will subside by itself spontaneously within 5 to 10 days. But in severe cases, when you are antibiotic and whatever the medications you are applying, if it is not giving good results and the patient is not at all comfortable, then we have to do certain investigations like conjunctival swab. And the swab should be taken from the inferior tarsal conjunctiva with the Johnson bud, or we can take it with sterile buds. And then they have to be seen for organisms. So a gram staining has to be done. We have to find out whether gram-positive organisms are involved or gram-negative organisms are involved. And coming into the culture, we have got chocolate agar, Thayer-Martin agar, then we have got other cultures also, blood agar, like that, to find out, to confirm what is the organisms present. And then from the culture, after 48 to 72 hours, we can get the material from this culture and we can focus it in the microscope and confirm the organisms. Of course, in a case which is responding to the treatment, we can do PCR, that is polymerase chain reactions can be done. And coming into the chlamydial investigations, we have to do Giemsa staining for basophilic intracytoplasmic bodies, and we can do enzyme immunoassays for direct antigen detection, and direct immunofluorescence detects elementary bodies because that is responsible. So we have got elementary bodies, reticulum bodies, and inclusion bodies. So the elementary bodies will go and attack the cells, and the elementary bodies will form reticulum bodies, and the reticulum bodies will release inclusion bodies. So we can see these bodies through investigations. And what we are going to do after investigation, of course, I told you nearly 60% of the cases they resolve within 5 days without treatment. And we have to give antibiotics. Antibiotics commonly we use fluoroquinolone antibiotics like ciprofloxacin 0.3% or norfloxacin 0.3% or moxifloxacin 0.3% or gatifloxacin. Previously we have got a sparfloxacin. So many things have come. The latest fluoroquinolone antibiotic is bacifloxacin. That is the latest one. How much we have to apply? We have to apply very frequently, for every 1 hour we have to apply for initial 24 to 48 hours. Then you can taper it for 4 times up to a week. Of course, the systemic antibiotic can be given if the severity of the infection is due to gonococcal or Haemophilus influenza or meningococcal conjunctivitis, if the patient has already got a mucopurulent severe discharge with the membrane formation and petechial hemorrhages. And patients, I told you, the patient will have severe photophobia, so you have to prescribe dark goggles because the patient has to be comfortable. And we have to irrigate the discharge. So a lukewarm warm water or saline should be applied once or twice. We should not keep washing every 5 minutes or 10 minutes because we have got an enzyme called lysozyme. So that lysozyme will get washed away by this continuous irrigation. So continuous irrigation should not be done in cases of conjunctivitis. Of course, lot of people are wearing contact lens. You should see that contact lens you should advise to discontinue. So the patient should not wear continuously the contact lens whenever there is eye is red and filled with discharge. So if they are wearing contact lens, 100% they will develop corneal problems. They will develop severe corneal ulcer and the problem will worsen. So you should not wear contact lens when you are having infection. And of course, you have to wash your hands very frequently and see that you use a separate towel, because we all know that these infections are transmitted directly or by fomites or by some vectors like trachoma. We have this house flies. This is one of the commonest vector we have. So we have to use separate soap and towel. So when to think about steroids? Say never to steroids. You should not use steroids in a case of acute infections. So when steroids can be given, if the patient has got in a superficial punctate keratitis, say a viral infection, and if the patient's corneal involvement is there, and if the patient is not at all comfortable with the treatment what you have given earlier, you can start him on low dose steroids. So the low dose steroids means you can use lotipret 0.5% or you can use fluorometholone 0.1%. So these low dose steroids can be advocated in conjunctivitis if it is associated with pseudomembrane or membrane formation, or if the infection is having corneal problems, we have to start low dose steroid for a minimal period. Then only the patient will be comfortable. Coming into the chlamydial conjunctivitis, we have got a thing called Vision 2020. In that, we have got a strategy called as SAFE. What is SAFE? SAFE is nothing but the patients who are developing trachoma, they will have initially the lid involvement. The lid will have papillae formation, then follicle formation, then leading to scarring, and you can see this scarring as alt line in the sulcus subtarsalis, and they can produce mechanical ptosis. Whenever there is a mechanical ptosis, patient can develop a trichiasis and it will go and produce problem with the cornea. It can produce epithelial erosion, it can produce ulcer, it can produce a lot of infection. So we should do surgery for this trichiasis. That is yes. Then coming into the antibiotic, what antibiotic you are going to give for chlamydial infection? You have to give oxytetracycline. You have to apply 2 to 4 times for a period of 15 days. Then facial hygiene should be maintained. That's very important. Some people, we have to keep washing our face because we are continuously exposed to outside atmosphere and environmental contamination, and see that the facial hygiene is maintained. Of course, the environmental improvement, the sanitation, the water we drink, the places we travel, and should be neat and clean. Of course, the antibiotic should be administered to the affected people, and we have to cut down the cost for, but I told you the vectors. In case of trachoma, it is prevailing in some of the parts in India. They say it is mainly due to surma. So the surma which is used from the same container should be discontinued. So we have to take all precautions in avoiding the vectors, say housefly or the surma. Same container, the surma is being applied and the conjunctivitis is spreading. So we have to take care of that also. Of course, azithromycin has got a very greater role in treating chlamydia. We have to give 20 milligrams per kilogram of the body weight up to 1 grams. So that is a treatment of choice for chlamydial. Then facial cleanliness. So this is something about SAFE. SAFE strategy should be maintained in all chlamydial conjunctivitis. Coming into another group of conjunctivitis which is very commonly seen is allergic conjunctivitis, and we get allergy in so many things. We are using soap. People see the advertisement in the TV and the movie, and they start using various types of soaps, change their cosmetics, and this is one of the commonest cause for allergic conjunctivitis to occur. So these allergic conjunctivitis can be seasonal. Sometimes during the pollen season in abroad, they develop this allergic conjunctivitis. And this pollen not only produces allergy, they have intense itching. And this pollen, we call it as seasonal. Perennial means I already told you, due to the cosmetics or due to certain food, or sometimes the skin. When they touch with the skin, they develop. And sometimes we get people, they are allergic to gold. So if they cannot wear gold for a long time, they will start itching. So this we call it as intense allergy due to gold. And what we are going to do for these patients? So allergic conjunctivitis, the patients will have mainly redness, intense redness, and they will have itching, one of the commonest complication. Not only that, they will have a ropey secretions. They will have a whitish discharge in the lower conjunctival tarsal plate. And coming into the one type of conjunctivitis we see commonly in the children, vernal conjunctivitis. Vernal conjunctivitis is otherwise called as spring catarrh. It is commonly seen in the summer months. The children will have all the time their fingers will be on the eyes, and their severe itching will be there. And these people, it is of two types. Either it may be a bulbar type or palpebral type, and we get lot of follicles occurring over the limbal portion of the conjunctiva. We call it as Horner's Truntas spots. It is one of the commonest condition we see in children. And what we are going to do for all these allergic conditions? First of all, we give anti-allergic medicines, namely antihistamine. We all know we have to prevent the release of histamine. So for that, lot of things are in the market. We have got acylastine, then we have got olapatidine, then pipostin hydrochloride. So now we have got alcaftidine. So many antihistamines are available, and one is having advantage of the other. But people, they feel that applying olapatidine for a period of 1 week to 10 days is giving good results. It prevents the release of histamine. Of course, the vasoconstrictor like oxymetazoline can be applied. And what are the other things can be applied? Anti-inflammatory agent, ketorolac-tromethamine, diclofenac sodium. All this, how this acts? It acts on the cyclogenase pathway, and it prevents the release of arachidonic acid. So whenever the release of arachidonic acid is affected, the patient's itching comes down. Not only that, we have to keep using topical steroids like fluoromethalone 0.1% or lotipred 0.5% can be applied in order to reduce the severity of the allergy. And of course, if there is a secondary bacterial infection, antibiotics can also be added. Suppose if the patient has got excessive mucus, we have to give 10% acetylcysteine. Then immunomodulators, the role of immunomodulators is also there. We have got cyclosporine, 0.5% can be applied, and of course tacrolimus 0.03% can be advocated as an ointment to prevent the allergy occurring very frequently. So to prevent the allergy in the future, people are using tacrolimus for a long time to prevent the release of histamine. And of course, superficial keratectomy. So whenever there are plaques due to an ulcer, I already told you some shield ulcers due to vernal conjunctivitis can produce a plaques or some debris, and we have to clear all these things. And superficial keratectomy can be done to allow for effective epithelialization. Of course, artificial tears is the main drug we have to apply for all allergic conjunctivitis, because the patients with whatever the type of conjunctivitis, they are prone to develop dry eyes. So artificial tears should be substituted in all cases of conjunctivitis, especially allergic conjunctivitis. And coming into the patients who are having eyelid problem like mechanical ptosis, or if the patients may be having a lot of papillae formation. So we call it as giant papillary conjunctivitis, GPC. So whenever a patient has got GPC due to allergy, we have to see that steroids are infiltrated there. Sometimes we have gone to an extent we try to excise this papillae formation to get rid of this. So GPC can occur not only due to allergy, it can be due to suture induced. After the cataract surgery, the suture can induce, and of course, the ocular prosthesis also can lead to GPC formation. So, giant papillary conjunctivitis we should remember, and whenever a patient says that he is not comfortable in the upper lid, we have to evert the upper lid and see whether the follicle or papillary hypertrophy is there, and accordingly we have to treat. Suppose if the ptosis is not relieved and excessive ptosis is there, sometimes there is a role for Botox toxin also. And sometimes when you want to excessive dry eyes are there, we can do a lateral torsography. And what are the complications of this conjunctivitis? So I already told you, lot of misdirections of the lashes can occur. We call it as a trichiasis, and the corneal involvement can occur. Of course, if the ulcer is invaded most of the stroma, it can lead to perforation. So these conjunctivitis in long run can destroy the goblet cells and the ductules of the lacrimal gland. So dry eyes can occur in all types. So dry eyes, corneal involvement like superficial punctate keratitis, ulcer formation, and in the lid we can get trichiasis. And of course, whenever the trichiasis is there, there will be lid abnormality. So how to prevent the conjunctivitis? So simple hygienic measure. So we should keep washing the hands, and whenever we apply drops to concerned person, we should be very clean, and the bottle tip should not be touched. And the patient who are having this conjunctivitis, they should not be done procedures like gonioscopy or tonometry, because it can, in a crowd, the infection can spread from one person to another. See that the person is not infected, and then you do the procedure. Suppose if the patient is having some red eye with some discharge, never do this the procedures, because it can contaminate other people. And ask the persons who are having conjunctivitis to use separate towel and soap. Even the bed sheets and pillow covers also should be changed. And hand washing is very important to the person concerned and also to the person who is applying drops. And alcohol based hand rubs are a good alternative for disinfecting hands. So thank you very much for the patient listening. I think I have covered almost the basic concepts of the conjunctivitis, and if you follow this, definitely conjunctivitis can be prevented, and conjunctivitis can be diagnosed as early as possible, and it can be treated effectively. Thank you all. I hope that what are all the slides I've shown you earlier and what all the discussions we made earlier is everything about conjunctivitis, and you people might have understood conjunctivitis in detail. And I must thank the management and the Balaji Medical College Dean and others for giving me this opportunity to talk you on conjunctivitis in detail. Thank you all.